Good evening, everyone. My name is Jeremy Rahman, and I am a member of the EvoEndo marketing team and your moderator for this evening. I am super excited to present the first in a series of webinars that we will be rolling out throughout the remainder of the year. It's my pleasure to introduce you to our host this evening, our physician founder and chief medical officer, Dr. Joel Friedlander. Take it away, Joel.
Thank you so much, Jeremy, and thank you to all our attendees this evening. All of us at EvoEndo are so honored that you are joining us tonight. We want to thank everyone for attending our first ever webinar. As a company dedicated to evolving endoscopy, you know our name, into the 21st century, we are hoping that this series helps prompt good discussions to help bring a better endoscopy experience to our community. This year, we'll be featuring a variety of speakers and guests from around the United States and the world, discussing various topics ranging from different medical disease states that endoscopy can be used for, ideal methods to optimize an evolved endoscopy, and experiences from medical team members about their ideal way of treating and diagnosing their patients. We promise they all love picking others' noses. Remember, you can pick your friends, you can pick your nose, but only T&E experts can pick their friends' noses. Tonight, we are very excited and honored to have 3 special guests, which we'll introduce shortly. As you are aware, I'm very honored to be a part of EvoEndo, a startup company out of the University of Colorado, and was one of the co-founders of our company dedicated to improving the endoscopy experience for our patients and improving patient care. When I was in medical school, I truly never realized how each of us has the opportunity to help transform not only the care of our individual patients, but help others, providers, and physicians as well. When we all started out as an aerodigestive team in 2017, none of us knew the power of medical innovation would have and how much hard work it would be. It has truly been a team approach and a collaborative effort to bring our experiences, our ideas, and new devices to patients and providers around the world. Our team's dream became a reality when EvoEndo's ultra-slim endoscopy system was granted FDA 510(k) clearance for patients 5 years of age and older on Valentine's Day in 2022. As of today, over 11 medical systems are now utilizing our devices, training systems, and methods to help improve the care of their patients. We want to thank everyone in those health systems. Over 175 cases have now been performed around the United States. Thank you for all your support. Our system includes an ultra-portable controller that is less than 2 pounds and a single sterile-use 110 centimeter length gastroscope that enables transnasal EGD and biopsies with readily available biopsy forceps and the full capabilities and functionality of a much larger diameter gastroscope. Our team at EvoEndo is dedicated to providing the services to help others evolve their patient sedated experience to sedation-free, or help others think through the possible uses of an ultra-slim endoscope could be used in their practices. The sedation-free option may help decrease the patient's time needed for the procedure, no general anesthesia is needed, and improve the time to a medical diagnosis. It also has the potential to open up access to endoscopy in a medical center. Many health systems have also found EvoEndo system that features an optional virtual reality patient experience kit to help create a well-rounded patient and family-centered experience. To briefly review, the world's thinnest single-use gastroscope has features that were built around our clinical team's experiences and needs for an evolved sedation-free endoscopy experience. It was designed to be an ultra-portable 2-pound controller system and always be available without the concern for washing or breakage in an office setting. Being a Colorado-based company, we also wanted to make sure it has the potential to be recycled if the medical center has such facilities. It provides a 3.5 millimeter outer diameter for the smallest of nasal or other anatomies. It has a 110 centimeter length to allow for full transnasal or transoral EGD with or without biopsy. It also enables other diagnostic or therapeutic procedures requiring an ultra-slim profile, including tube placement. It has a slightly stiffer shaft and 4-way steering to help navigate the floppiness found in other ultra-slim scopes. And of course, air, water, and suction, readily available to help clear the upper GI tract secretions. It was a dream come true to develop the system, and our team thanks you for attending our webinar today. I am now very honored to present tonight's speakers, 3 amazing nurses who are experts in sedation-free evolved endoscopy, Molly Mackensen and Mary Witzlib, who have been the heart and co-pilots of the new Unsedated Endoscopy program at Children's Wisconsin. We are so fortunate to have them present tonight. They'll be sharing with the group their experiences on starting a new program from scratch and their role in assuring its success. And of course, the man that needs no introduction, my friend and manager of clinical support at EvoEndo, Clint Smith, the nurse that helped build and pioneer pediatric sedation-free nursing in his previous role at Children's Colorado. Following their talk, there will be a question and answer session. Tonight's objectives that will be covered by our speakers will be how to identify the best location for an evolved sedation-free endoscopy, what supplies may be needed and how to obtain them for the procedure, how to obtain skill competency and attainment strategies when rolling out a program, the role of different team members involved in the procedure, and needed resources, various strategies and roles around patient preparation, and finally, patient support needs that may be needed to be addressed during a procedure. Molly, I would now like to turn this over to you to start, and thank you so much for speaking tonight.
Hi, everyone. Thanks, Joel. So I'm Molly. I am a nurse from Children's Wisconsin, and I'm going to share with you some of the insights on what it takes to launch a sedation-free transnasal endoscopy program from a nursing support perspective. So a little background about me and our transnasal endoscopy program. So I am a GI diagnostics nurse, which means I specialize specifically in specialized GI procedures, things like motility, pH impedance, and of course now TNE. When our facility decided to start a transnasal endoscopy program, our nursing team was asked to help support its development and launch. So we saw our first patients in October of 2022. For our TNE program, we decided to see patients in the clinic setting, and then it is our GI diagnostic nurses that do support the providers and the patients in these procedures. In some other programs, they do sometimes have the nurse clinicians help or sometimes use the nurses from the endoscopy teams. And it can also be done in an endoscopy room. Details will vary program to program, but all the concepts that are listed here will remain the same. And it's just really important that all the parts work together for success. So I'm excited to share with you all the insights that we gained when launching our Unsedated TNE program. Okay. So one of the first things and a really important thing you need to do is figure out where you're going to perform your TNE procedure. One of the things you need to consider is if the room you pick has enough space. There will be at least the provider performing the procedure, 1 to 2 nurses, of course the patient, and usually 1 to 2 parents in the room, if not more people than that. And you just need to make sure that everyone is able to move around the room comfortably and do the jobs that they need to perform. Equipment-wise, you will have the cart that includes a couple of monitors as well as the biopsy tray. And then for the patient positioning is really important. We do recommend typically that an ENT chair is ideal. This allows the patient to be upright and keep the patient at the physician's chest level, which we find is most comfortable both for the patient and the provider. We did learn that it is important to make sure that the chair has enough space to go back if needed for patient comfort, as well as having adjustable lighting and climate control. A cool room is really important. Patients do tend to get a little warm sometimes. Another thing that we think is really important and do recommend is that you have 2 rooms. So we say, have one room that's the procedure room, the room where all the equipment is, where the actual TNE and any of the invasive pieces of this procedure take place. And then you have a second room that we like to call the pre and post room. This is where you do everything pre-procedure and post-procedure. This just keeps everything less intimidating, calmer for the patient. And, when we were developing our program, EvoEndo was nice enough to come out and look at some different spaces with us. And ultimately, we decided to set our location up in the clinic because it was most convenient. That's an important piece too. What's convenient for the staff, what's convenient for the patients, and what's convenient for things like supplies. So once you have a location, then you got to start gathering your supplies. And it's actually kind of surprising how many supplies you might need to figure out. Because we were working with EvoEndo, they were nice enough to give us a list of the supplies that we would likely need. Once we had that, we sort of adjusted it based on our specific facility. And then we started looking for where to get them. So we found, hey, let's get them from the easiest place possible. So we walked over to our clinic supply room and saw what was already available. And from there, we were able to find about 50% of what we needed. So that was nice and easy. But for the rest, we had to start getting a little more creative. And you can see some of the supplies here. So things like the forceps, for example, we had to go borrow from our surgery area. Some things we had to get from pharmacy. We had to talk to pharmacy about getting special permission to keep the lidocaine and the Afrin locked in a drawer right in the TNE room. And for a couple things, we had to be a little bit creative. For example, the EvoEndo team did recommend a very specific atomizer for giving the nasal lidocaine. but our facility didn't typically carry that atomizer, and they preferred not to have to order that for us. So we had to look at what other options were available, and we tried a few different things, and we found one that works for us. So you have to keep an open mind with anything too. You have to think about where you're going to store supplies, who's going to order supplies, if you have to consider them in the charge or the cost. It's the other piece is anything that needs to get cleaned or go down to sterile processing. One of the beautiful things about the EvoEndo scope is that it is disposable, so it takes out a lot of that. There are a couple odd things that we occasionally need that do still need to get cleaned for the biopsy collection, but that's very rare. So that's a huge perk. But that's just something you need to consider. Figuring out the supplies is honestly surprisingly complex, and we're honestly still perfecting it, but it's definitely manageable. So now that you kind of have a place and what you need to do, you need to get your skills together in order to do the TNE. From a nursing perspective, there's really two big skills that you need to develop. That's supporting a patient for an unsedated procedure, and then the biopsy collection. With my background as a GI diagnostics nurse, with doing unsedated esophageal manometries, anal rectal manometries, pH impedance, as well as supporting patients through long motility studies. That was something I really felt comfortable with going into starting this program. But really, any nurse has skills that they can use. Whether you're comfortable with IV placements, placing NGs, or even just helping an anxious patient. Those skills do remain the same no matter what the context is. So if you just rely on those skills in your nursing judgment, you're going to be okay. Every case that you'll get more comfortable and you'll learn more tips and tricks, but just rely on those skills that you have, and you will be able to support these patients. For biopsy collection, hands down, my number one recommendation is if you are able to get some hands-on experience. So we were lucky enough that we have a really good relationship with our endoscopy team here that do the sedated endoscopies, and they let us actually shadow and work as a scrub nurse for a couple of shifts. And just being able to take the biopsies in a sedated setting, getting that hands-on experience made all the difference in the world. But for me, it was honestly more than just learning how to use the forceps for collecting biopsies. It was everything that goes along with it. And for me, that was the hardest piece. So it's learning, hey, if it's this biopsy, it needs to go in this medium, and then it needs to go to this lab, and it can get transported this way. But if it's this one, it gets transported that way. And the order has to look exactly like this, and it has to be documented exactly like that. So there's a lot of intricacies that you maybe wouldn't know unless you get your hands-on experience, or at least have a really good conversation with someone who has that experience. And I still have a cheat sheet that helps me when we have some of these things come up, but it's definitely obtainable. And then I always like to throw this out here. This is likely a new skill for your provider too. So do whatever you can to support them. We really, recommend getting some time to practice together. You guys are a team. So if you have an opportunity to do dry runs, if you have a model, which is something EvoEndo can sometimes offer, pretend that it's a real patient. Do a full scope on them, room them like you would. It can just be a really good opportunity to learn how to support each other and get more comfortable working together. And then just an additional shout out for EvoEndo, they do provide a learning home where they give you a bunch of material that helps you gives you tips and tricks on things you might want to consider. We all completed it. It definitely was helpful. But on top of that, reaching out to other centers that have similar programs is also a really good resource. And we definitely did that too. So now that you kind of all the pieces put together, you need to determine what your workflow is going to be. Your workflow is things like what the path of the patient is going to take when they come to one of these visits, and who does what job. One of the things that I know some programs do differently is who gives the lidocaine. So in our center, it is the nurses that give the lidocaine. I know some centers prefer to have the provider give the lidocaine. But that's an important thing to determine ahead of time. You don't want to be making those decisions the day the patient shows up. And I put workflow right next to the charting because for us, and I would highly recommend this, building your electronic health record to work alongside your workflow is very, very useful. It prevents errors. It makes charting quicker. And what I mean by that is our electronic health record, our transnasal endoscopy visits, are set up in a way that we have a visit navigator that is laid out in order of the way we do things at our visit. So when it comes time to give the lidocaine, the place to order the lidocaine and document the the administration is right where it would be in the visit. Same thing with the orders and the biopsy collection. And this just prevents wrong orders, especially for those biopsy collection, as I mentioned, that's a little particular. And then when it comes to patient review, patient preparation, it just makes things a lot simpler. And then I'm going to put a blurb out there that the document side of this, with any new skill, any new program, there are going to be documents that you need, whether it's be policies, competencies. So just reach out to your leader, your supervisor, see whatever you need to get done and just see what role you have in supporting that. And then, of course, there's educational materials. Anytime you have a new procedure, you're going to have to do education. Super important, but I'm not going to get into it because Mary's going to share a lot of tips and tricks about that later on. So, you have to do team building and collaboration. This is a team effort. It's a team procedure. And that just means a few different things. Some of the things I already touched on, but it's also things like considering who else is going to help you with these procedures. So some centers, including ours, we do use an MA to help room the patients first. So we wanted to bring the MAs in early, just let them know what the role is going to be, bring them up to speed, familiarize them with the procedure. But it's also things like as you're building this, you're working collaboratively with a lot of different players, a lot of different people, and just taking the time to build those relationships so that you feel comfortable going to them for help, reaching out with questions, and always be thankful. People are usually willing to help, but they're going to be a lot more willing to continue supporting if you, show that you really value their expertise and are always thankful. I think of when we went live with our first patients, our poor IS guy stayed with us late 2 days in a row, and he was so helpful and he was so gracious. But because we had started talking to him months in advance and always, talked openly, and we were always gracious and we were always, looping him into things, it made those 2 long days much simpler, much more comfortable for everybody because we went that extra mile from the get-go. And then, of course, once you're ready to see patients, you have to know what kind of patients you're going to see and how those patients get referred. So I would say I would recommend having a short-term and a medium-term goal. And what I mean by that is, for us, our short-term goal, our first patients, we said we wanted them a little bit older, so roughly 12 plus. We wanted them low anxiety, more higher motivated. And then we specifically said we were seeing patients with EOE that have had a previous sedated endoscopy. Now that we've been seeing a few patients, we have seen some younger kids and we're slowly opening it up to a few more diagnoses. And then also who's allowed to refer patients is important. So most of our referrals do come from our providers that do the actual TNEs. However, we do also take referrals from internal GI providers, and we're taking a few more as time goes on. And then, what is the nurse's role as far as the nurses that do these procedures in managing the referrals? So we don't necessarily have much say or management in like who actually gets referred. However, I do recommend just keeping a list and keeping tabs on like how many patients are being referred and their ages, just so you can anticipate numbers and the program's needs and support them as they come up. And then, of course, you have to build a schedule to put these patients in. You need to look at the provider and staff availability. You can consider patient, convenience. Feedback from patients has been they do like the mornings. There is an NPO requirement for this procedure. That's usually easier if it's in the morning. Obviously, that's not always doable from a provider standpoint. Providers, say that they like it either at the beginning or the end of the day. So if they already have clinic going on, do it before clinic starts or do it after clinic starts. And then I would recommend when you're starting out to allow at least an hour for these appointments. All right, so this is a broad overview of kind of everything that goes into building a TNE program from a nursing standpoint. But why does it all matter? Why should the nurse play this integral part in building this program and this big part in program development? I do truly believe that the nurse has the ability to be the pillar for providing an individualized yet consistent experience for all patients and the providers too. You may work with different providers with different styles. You may have patients that are really loyal to one provider, but needs to have this procedure done by a different provider. You have the ability to make that patient's experience similar while still meeting their needs with any combination of factors. And that creates an environment that breeds confidence and trust for the patient, the family, and for the staff members. And then by taking an active role and being so involved in the program development and management, you create such a valuable toolbox that you can use to continue to support and make adjustments to the programs as it grows and develops. If we hadn't been so involved and so deeply committed to this development, we would have been so significantly less prepared for the unexpected. We had to make several changes to what we thought, our normal was going to be within the first few weeks. Most notably, one of our first patients had a syncopal episode. We weren't prepared for that, but we were able to calmly react to it and calmly make the changes that we need without it being a big deal, because we had all the research, all the tools, everything that we needed already prepared, because we did all this work ahead of time. And like anything, use all the hard work you put into creating this program and all your experience from this or from any nursing or anything in life that you've done is only going to help you. You can make the difference. Patients and families and providers will look to your expertise. If you are confident or if you are calm, they often will model your behavior. And just always remember that it is a team effort. Providers and nursing, they work together. Trust each other to do their roles, give credit where it's due, celebrate together, problem solve together, and don't be afraid to ask for help. That's always okay. And when you're ready, like I'm doing now, share the knowledge you've learned. And last but not least, as I've kind of alluded to, there's a lot of players in the sedation-free endoscopy game outside of the initial TNE team. Here's a list, and I'm sure there's more of all the different people that helped us and that we've worked with. I can think to a specific meeting where about half of these people was on the meeting with us, and it was all just to get the orders right in our EHR build for the biopsies. But it took everybody to get it right, and it was worth the effort to get everyone to work together and sync together. And I want to put a special shout out to our program manager and to our providers. They really put their trust in our nursing team and gave us the support that we needed to build this program, and that really made a big difference. You'll also find helpful resources with EvoEndo or whoever your vendor may be, and also always can look to other centers for support. I have greatly enjoyed my part in building and supporting our Unsedated TNE program. It has been incredibly rewarding to offer this procedure to my patients. And now I now hand it off to my friend and my co-pilot, Mary, to discuss the very important piece of unsedated TNEs, which is patient education.
Thank you, Molly, and thank you everyone for joining us this evening. Like Molly, I too am a GI diagnostics nurse at Children's Wisconsin. And so now let's talk about preparing and supporting the patients and the families. It is very important that the patient family members know what to expect from unsedated transnasal endoscopy. When at our institution, the initial discussion regarding TNE takes place in the GI clinic. And one of the first things that we assess is this procedure a good fit for the patient and the family? Some of the things that we share with them when discussing this is that there are no needles, there's no need for general anesthesia, and that it has a greater than 95% success rate. Every family leaves that initial clinic visit with a teaching sheet for them to review on their own. We also share with them, we also take advantage of the many EvoEndo resources, such as the family informational video. Very early in the process of setting up our program, it became clear to us that child life would play an integral role in the success of this program. So with that in mind, we reached out to our child life specialist and we met with her and her leaders several months prior to our program opening. And we met with them a few times. And in that process, we developed a plan and a process for how they would support these patients. For instance, our child life specialist calls every first-time family 10 to 14 days prior to the procedure. She assesses the parents as well as the patient's level of anxiety, their previous experience with procedures such as lab draws and G-tube placements, sedative procedures, She asked about any coping strategies or comfort measures that have been helpful to the patient in the past. And she also will email them a prep book on unsedated transnasal endoscopy that she developed with the help of the EvoEndo educational resources and by reaching out to other child life teams. She does also have equipment, demo scope, and an atomizer that she does do show and tell with the patient on the day of the visit. In addition to the child life specialist, one of the GI diagnostics nurses contacts the family about 7 to 10 days prior to the procedure. During that phone call, we discussed the TNE procedure in detail. At our institution, we have them be NPO for 4 hours. Some centers, they say 2 hours if they're only going to do an examination of the esophagus, and 4 hours for a full EGD examination. We do recommend that they have a clear juice 2 hours prior to the procedure. We found that has helped prevent some of the patients coming in hypoglycemic. We do also allow 2 parents or guardians to stay in the room and observe the procedure, but we let them know they don't have to. They're welcome to, but they don't have to. If they are going to stay and observe, we advise them that the images on the monitor that they'll be viewing are magnified by 30 times. And that if they feel the need to step out during the procedure, that is okay. We also, at the end of that phone call, we also send a link, a summary of what was discussed via the electronic health record. And in that, we also shared the link to the EvoEndo family informational video, which is a really cute video. Most of the kids really like it. It's www.evoendo.com video, and that's down at the bottom of the screen. So this is on the day of the visit. Like I said, the child life team specialist meets with every family, and she will have the demoscope and atomizer there, and they come up with a plan for the procedure. She will offer to stay for the procedure if that's necessary. A few times they have, but it's not always necessary. The GI diagnostic nurse also meets every patient and family. She once again reviews what's going to happen. Some of the things that we share is that the lidocaine does not taste good. They will feel a lump in their throat from the numbing medicine. At one point, the doctor will ask them to swallow, and because of the numbing medicine, they may need to really focus to swallow, or may need to do like an exaggerated movement to swallow. We also inform them that they may feel some movement and they may feel some pressure in their chest, but it won't be painful. We address any questions or concerns that they may have. We set the expectations with the patient and the parent, and we help them set up the VR headset and help them choose the show that they are going to watch. If the family member is going to observe the procedure, then we prepare them as well. All right, so some of the lessons we have learned, like Molly said, when you're starting the program, it's good to go through the flow. And she did mention we do have a pre and post room at our facilities. So we use a different clinic room separate from the room that the procedure is performed in for our pre and our post portions, because we want to make sure to create a friendly, non-threatening environment, free of any scary looking equipment. And so with that in mind, the nurse sets up the single-use gastroscope in the procedure room prior to the patient and family being brought into it. And regarding any, your pre-procedure guidelines, we just followed our institution's policy regarding that, and that's what we would recommend for you as well. So during once in the procedure room, and this is actually a photo of our procedure room at Children's Wisconsin, and it's important to establish roles. Like Molly said, at our facility, it is the nurse who administers the numbing agents. Some places it is the physician. And make sure to have an emesis bag on hand. The nurse will hold the emesis bag in front of the chest during the intubation of the scope. We keep it handy throughout the procedure, but that's the only time we really have it right there in front of the patient's chest. The nurse also assists the physician with the biopsies during the procedure, and she's also doing continuous assessments and reassurance, assessments of the patient and reassurance to the patient and the family as well. Molly mentioned that syncopal episode before, so we have found that even though we tell patients to be NPO for 4 hours, some are NPO for much longer, like 12, 14 hours. So if that's the case, we do have them take a few sips of a clear juice, not red though, just prior to help prevent that syncopal episode. And immediately after the procedure, we move the patient back to that pre and post room. We offer them a popsicle, again, not a red one, or apple juice. And they go back to that room right away. The doctor goes, gets the images off of the monitor and does the report that the parent goes home with, and comes into the room and has a real in-depth discussion with the patient and the family. And what's really nice, these procedures are really, really quick. Right now, we are averaging 7 to 9 minutes per TNE and dropping. Each one gets a little bit faster. When we started, we were averaging 12 to 15 minutes per TNE. And so, like anything, the more you do, the better you get. And since they are so quick, you really have no time to do any of your documentation in the electronic health record. So we do all that at the end of the procedure once the patient is discharged. And what's really nice about this single-use gastroscope is that it's single use. You just simply dispose of the cleanup and turnover of the room is really easy. You simply just disconnect it and put it in a biohazard bag, or you can recycle it if your facility allows that. And it's just, that's the beauty of it. There's no, you're doing enzymatic cleanser. There's no flushing of the scope. You just simply place it in a biohazard bag and be done with it. And then we just wipe down the ENT chair and the surfaces, and we're ready to go for the next case. And so thank you. And I would like to introduce my colleague and my mentor in this, Clint Smith.
All right, thank you, Mary. Thank you all again for joining us. My name is Clint Smith, and I'm a nurse that works as the clinical specialist for EvoEndo. As Joel mentioned, I worked with him in the Digestive Health Institute at Children's Hospital Colorado, helping to build and grow and run that TNE program before having the opportunity to come and join EvoEndo. While at Children's Colorado, I was directly involved in over I think 1,000 TNEs on patients ages 5 and up. And I've had the privilege of working with other providers at Children's Colorado and teams across the country who have started and are in process of starting a TNE program. So I'm excited to be here to you guys talking about all my experience with TNE, working with a wonderful team like Mary and Molly, as well as other centers across the country. So when Joel asked me if I was interested in helping him with something new that he was doing, I said, sure. I didn't really know exactly what I was getting into, but I had to learn on the fly as we were some of the first ones to be trying TNE on pediatric patients. And over the next few years, we built and grew the TNE program into what we felt was a pretty well-oiled machine. But how did we get there? So a few things we've found to be extremely important in working as a team. Number one is good communication and cooperation. Preparation, as Mary and Molly both have discussed here just a second ago, how they prepared as a team, working with different players involved to come, up with the plan to have everything in place, but also in preparation, regarding the patients and education, because we've learned that if the patient knows what to expect, can make the procedure and everything go a whole lot better. So no surprises, letting them know everything that's, going to happen or what they may feel, being flexible, to adapt and maybe do or try things differently. Like in Joel's case, doing unsedated TNE, that was something new and something different, and we did it and ran with it. And then persistence, what we've learned is to stick with it. This is a very, very doable, procedure and technique, and it can be very, very well tolerated. It's a procedure; it's not for everyone, but it's an amazing option, and we're just super excited to be able to, bring this to patients. So when it comes to communication and cooperation, we learned as we went. That's a good idea to know, who is doing or saying what. When you get a bunch of people in a room doing a procedure on a patient who's sitting there awake, watching some virtual reality, it's good to kind of have a plan in place. And in the beginning, as Molly said, that nurse is that pillar of the program, a Jack or Jill of all trades in the nursing profession, supporting and monitoring everyone in the room, whether it's the patient, the parent, or the provider. If you're kind of helping keep track of things, this does enable the provider to focus on the procedure as they're getting comfortable. And remember, for most nurses or even techs, sometimes unsedated procedures of any shape or form is usually not something new for us, as Mary and Molly can attest to. As they said, the NG tubes, nurses and IV placement, manometry, catheters, things like that. Managing patients that are awake is not something new. But also don't forget there are others in the room. It could be a nervous parent, could be a nervous provider, hopefully a calm patient, but just, you're keeping an eye on everything. And something we learned with communication is that nonverbal communication can be best. But when did we start doing that? I'm glad you guys are thinking that, but long story short, Joel kicked me during a procedure, and he actually kicked me twice. It wasn't that hard. It's not as bad as it sounds. I thought he was just adjusting his stance, and his foot bumped me, but then he did it again. I looked at him and he was nodding his head. What was happening was this patient who was sitting there awake in a chair was hearing him say open and close like you would for a sedated endoscopy, and they were tensing up because they may have been a little more sensitive with the biopsies being taken, and it was making it a little more difficult for him. So I kind of figured out what he was going on, and we did some head nods the rest of the way. But after that, we had a discussion and came up with a way where he would do a head nod and say, mm-hmm, and I'd say, yep, quietly. I've seen other centers do it other ways that works, whether they say 1 to open, 2 to close, or a light, clearing of the throat. But, come up with a way that you can try to keep things quiet, because the more you talk, the more the patient hears you and is reacting and listening to what you're saying. Even if they're watching the VR, the show in the VR goggles, you want to try to keep them focused on that and not what you guys are doing. So, work on, coming up with something that works for you. We also developed hand gestures. So if you can see on the slide there's some pictures of how I would hold the forceps for Joel. One would be to help it make it where it's easier to feed the forceps into the scope, which can make the procedure go faster. The other was a way to signal to him how many biopsy pieces we had. So I didn't have to, talk out loud and let him know. And so, feel free to be creative, do what works best for you and your team, and maybe come up with something new. So, what worked best for Joel and I may not be what works best for your team. Be flexible, be adaptable. I've helped support multiple providers who had different methods and styles and even flows, and even different ways about setting up the room or positioning or techniques and how they do it, and whether it was the room and how we set up, or whether it was how tall or how short they were. These things do come into play, and you want to be mindful of that. It's really good if you do have a kind of a core team that you're working with, so the provider and the nurse or tech can establish that bond and that ease of working together and kind of understanding how each other works. But it's also good to have backups. Also different patient preparation styles, as Mary and Molly mentioned, and as I've said, you want to make sure that you are having good discussions with the parents and families and the patients beforehand, so they know what to expect. Joel liked to call the families, and I had other providers to work with that wanted the nursing team to reach out, and so it's important to kind of come up with that plan. And again, be flexible. Feel free to adapt. Make suggestions, changes. Nothing is set in stone. And just because I'm talking about doing it this way or that way, or Mary and Molly do it, one way or another, doesn't mean that's the way you guys need to do it, because nothing is set in stone. So patient management, it is a team effort. And a good team effort can go a long way to keep them comfortable. So, set, as we said before, and again, it's super important because I keep repeating myself and I apologize, but setting good expectations through pre-procedure education is really important. If they know what's going to happen, it can make things go a lot smoother. The lidocaine doesn't taste good. Yes, it will numb up your nose, but you will still feel stuff. If they know what to expect, it definitely helps out. Lots of positive reinforcement and encouragement is something that we've seen that can go a very long way. The you're doing well, remember taking your slow, deep breaths, but try to avoid asking them how they're doing. Because if you ask someone how they're doing in the middle of procedure, they're going to be thinking about that procedure and what you're doing. So I always suggest, don't ask them how they're doing. More of, hey, you're doing a great job. Slow, deep breaths. We're almost done. Try and figure out, what's your timing and have an idea so you can respond to them. I know we were asked a lot, how much longer are we done yet? We also had kids where the scope was out of their nose and they would still ask us, are we done yet? Is it out? And the scope had already been out. Working as efficiently as possible. Again, this is a procedure, they're awake. So the sooner you get in there, the sooner you do what you need to do, the sooner you get out, the better. And then using distraction and your redirection is really important. So what did we do if the patient was losing focus or starting to get a little anxious? These are things that you can do if they're getting nervous, but you can also do it when they're doing fine. It's reassuring to you, it's reassuring to the parents, to hear a verbal response, especially a nice one, like, if you ask them what they're watching on the VR. But, always, every so often somebody give them a reminder to take a slow, deep breath. Asking the patient to go ahead and swallow can be helpful. Sometimes they're holding their breath, which can, kind of pull the secretions in the esophagus. And you kind of see that on the screen when the provider's trying to get around and do what they need to do. You remind them about those slow, deep breaths. Try to make sure that they have something like a stress ball in their hands. It helps them give them something to do, to squeeze through the tough moments, or even just kind of fiddle with. You can ask them about, what they're watching on the VR. It's great, when you have a patient in there who's kind of anxious and it's like, hey, what you watching or what's going on, and they'll they'll tell you, and you can try and get them talking. If you have a parent or visitor sitting there watching this patient talking in middle procedure, can be very reassuring. Plus, it kind of gets the patient mind off of what's going on. As I said before, try to avoid asking how you're doing, especially if they appear to be doing okay. And at the end of the procedure, try not to ask them what they think. So again, just lots of positive reinforcement, encouragement to the families as well as the providers and the clinical staff. At the end of the procedure, great job everyone, because this patient didn't need to go through anesthesia. They're hopefully in and out of the hospital or your clinic in an hour or less, for a really super short procedure. Most of that time is for that prep and getting out of there. Again, I want to thank you guys all for coming. I wish I had more time to talk about this. I could go on and on about TNE. As you can tell, I kind of love it. Mary and Molly have been awesome to work with. So I'm going to pass it over to my friend and colleague, Joel, for questions and stuff. So again, thanks again, guys.
Well, thank you so much, Clint and Mary and Molly. That was absolutely amazing, and thank you for sharing your insights, your journey, your knowledge with our audience tonight and our participants. So I'd like to open up to the crowd. If anybody would like to answer or ask our experts any questions tonight, please feel free. Are there any questions? Please raise your hand if you'd like to do vocally, or to write it in the chat, and we'll let our team answer those questions for you.
All right, so just as a reminder for everyone, as Joel said, there's a Q&A icon at the bottom of your screen. So if you'd like to ask a question and type it in there, I can read it anonymously to the group. And then there's also a raise your hand icon as well. And then I can unmute you and we can, speak live. So we have our first raised hand. And I'm going to go ahead, and it's a Eunice Odiasi, and I apologize if I misspelled that or mispronounced that name, but I'm going to go ahead and unmute you right now. So
Thank
Eunice,
you.
Yep, there you go. Perfect.
Yeah, thank you. What a great overview of transnasal endoscopy. Yes, my name is Eunice Odiasi, and we're in the middle of starting our transnasal endoscopy program here at University of Virginia Children's Hospital. I did have a question from nursing staff for our nurses who, currently I'm working on training our first nurse, but as you all mentioned, it's good to have backups. I guess in terms of teaching nurse to nurse, what do you find is the most efficient and effective way to doing that?
Um, it's Mary. I think I'll answer that. That's a great question. Like Molly said, we did go down and work with our special procedure, which is our endoscopy suite. So I'm not sure what kind of experience your nurse has, but if you could get her to go and work, spend some days actually like helping with the endoscopy, that's huge. That's really good experience, and it's going to give her a lot of confidence. Like Molly said, with handling the specimens, how to take the biopsies, just all that stuff. That's really that all three of us went down and spent time in special procedures, and that was very beneficial. So that's the thing that I would recommend, is if you could get them to get some hands-on experience with that. I'm not sure if Molly has anything else to add.
I can add a little bit. So I absolutely echo what Mary says. But like, let's say you have one nurse that's already trained in TNE, or, you know, you're starting with one and you want to bring more nurses on, and that's just not an option. I think the more training and involvement they have, the better prepared they will be. But this is certainly something that in a pinch, a nurse could be taught to do. You know, I know that some centers have like a book that is like, hey, if you have to do in T&E, like, here's all the things that you need to know. I don't think that's the best way to do it, but there definitely is that capability to make like a step-by-step list of like, here's the most important things. You know, there was early on a day where, you know, 2 of our nurses, we have 3 that are trained, were out on unexpectedly, and I was there by myself, and it was brand new, and we just wanted an extra set of hands just in case. And I could bring someone up to speed, not to do it completely on their own. I still did it, but enough to step in. So I think it's a simple enough thing that you can have those helping documents, those helping step-by-step things to support, but ultimately it's going to be that hands-on experience, taking that time either in the endoscopy suite or doing other TNEs to really get the knowledge that you need.
Yeah, I didn't have any specific training because no one was really doing this. So like they said, I went to the down the procedure center, watched some endoscopies, help with the biopsies, and then I actually went up and joined, I think, saw like 2 TNEs done. And a respiratory therapist was assisting Joel at the time. And then they just pass it on to me, and I pretty much learned on the fly for myself. So as Mary Molly said, you know, there's ways, it's an easy way to do it, but then there's little things that can make it go really well, and stuff. So, you know, it's not overly complicated. It's just the finer things, and stuff. So.
All right, great. Thank you guys. Thank you for the question,
you.
Eunice. Did you have anything else to add, or did that answer your question?
No, that was great. Thank you.
Perfect. Okay, we have another raised hand here. It's gonna be Nicholas Soklas. I'm gonna unmute you. There you go. So go ahead and unmute yourself, and you're live, Nicholas.
Thank you very much. Appreciate that. Yeah, I've had some extensive experience with T&E. I reside, by the way, in Richmond, Virginia, Eunice. So if we can connect at some point, I think I can be helpful for you. But in the early years of doing T&E, when I was both at Pentex and with Vision Sciences, it was also very much giving the local anesthesia, the topical, the shrinking the anatomy in the nasal pharynx, and numbing the throat. But then after spending time with another friend of mine who's on this Zoom call, she's a speech therapist, her name is Carol Winchester, and observing Carol do the swallowing evaluation called FEES, endoscopic swallowing evaluations on patients of all ages, and seeing that when they do a FEES exam for the laryngoscope, which is the same size as this scope, she didn't give any anesthesia at all, because it would confound their examination of doing a swallowing evaluation. So I became more and more interested in, well, maybe we don't have to give so much topical, and that led me down this path to, you know, train doctors without any topical lidocaine, especially lidocaine. It's okay to shrink the nasal anatomy a little bit, but the lidocaine is something we completely went away from. And if you'd like to ask Carol she can also, she's on this call, she can also contribute her experience in doing transnasal endoscopy from a perspective of a speech language pathologist that deals in dysphagia. So just wanted to add that.
Yeah, thank you, Nicholas. Yes, we definitely at EvoEndo value our resident speech therapist Lauren Brown, who is an employee of ours, and that is her background. So she's been able to give us a lot of insight into some of the you know, kind of methodologies that you have described. You know, Joel, Molly, Mary, Clint, did any of you have anything to add to Nicholas's comment or comments?
No.
All right.
Yeah, no, I'm happy to talk a little bit about it. So I've actually done TNE without anesthesia, without the topical lidocaine. I've done it with lidocaine. I've had it done on myself without lidocaine. So I've kind of tried it both ways. With that said, in the pediatric population, it's some of those sensations I think are a little bit different in kids as compared to adults. But also with the FEES procedure is you also are evaluating something a little bit different than swallowing it and then obviously going down a little bit further. So I think, Nick, absolutely, you're 100% right, is there definitely are some patients that do very, very well without topical analgesia. There's quite a few that like it and need it because it makes it a more comfortable or tolerable procedure for them. But I think like Mary and Molly and Clint were talking about, it's very much you work with the patient to meet them where they're at to optimize their experience. And I think that's kind of what you're talking about as well too, is what is the best way to offer the best sedation-free experience for the families and the patients.
Yep.
All right, great. Okay, so let's we have another question coming in here, and this is for Molly and Mary specifically. So what was the most difficult part of getting your program up off the ground? And if you could only choose one thing to do differently, now that you kind of know what is involved, kind of what would you change?
Well, for me, the most difficult thing, I think, because I did have some experience. I did work in the GI endoscopy suite for a number of years. So I had experience handling biopsies and all that. So that wasn't, the most difficult part for me was, I think, the non-verbal communication, figuring out a consistent non-verbal communication that was going to work for both the provider and for us, for me. And also another difficult thing for me was, because you want the patient to be immersed in what they're watching on the VR headset, that it was hard for me not to want to talk to them, and to just, like, because you do want them immersed in that, like they're watching a movie. And so that was hard for me too, to realize all the patient distraction is not really up to me, because that's why we have the VR headset, and just let it do its job. So those were the two things that were the hardest for me. So, and I'm sorry, was there another part of that question?
No, well, just one thing you would do differently, if with the knowledge that you now have, in hindsight's 2020, what would you change?
What would I change? I think I would just, I guess, embrace that more. Or I'm not sure if there's anything that we did that I wouldn't do, or anything we didn't do that I think we should have done. I don't know if Molly has something, but I think just, embrace that this is different, and to take advantage of the VR headset and the goggles, and really just try to make it like the movie theater type thing. That was a bit of a change for me. So I don't know if Molly has anything to add.
Yeah, I would say for me, it would be more on the biopsy side. That it was definitely the most difficult part. Not so much taking the biopsies. That's a little clumsy if you've never done it before, but it was just learning all the intricacies. And I'm not even going to say that it was super difficult. I was just surprised by all that you had to learn. And, for the typical TNE, you don't even need it. You're not going to be doing all these crazy biopsies, but you need to know how to do them in case the need arises. And I found myself being really nervous, like, oh no, this first patient's going to need this, this, and this, and I'm not going to know where my stuff is, and I'm not going to know what I need to know. And so if I would tell myself to do something differently, I would tell myself it's going to be okay. Like, the worst thing comes to worst, you grab your cheat sheet, you ask for help, it's fine. And going off of that and kind of mirroring what Mary said about the communication, absolutely true. You want to try to talk about opening and closing the forceps as little as possible. You don't want to scare the patient. I love Clint. Clint prepared us very well, but sometimes I think we were a little too scared to talk. And there was a couple times where the communication was just breaking down. We didn't know what the physician wanted us to do. And I just learned, I said, you know what? I'm at risk of not putting this biopsy in the right jar or not doing what I need to do. I'm better off calmly saying proximal, distal, and just confirming that we're on the same page. Because for most of patients, that's not going to mean anything to them. As long as you do it calmly and you're not talking too much, you're better off getting the information that you need and getting that successful scope done versus taking the risk that you contaminate your biopsies or do something wrong. And the communication, we're still working on it. We'll get there. Most of the time we don't have to talk, but you don't have to be so scared of talking that you risk compromising the procedure.
Yeah, you don't you don't have to be silent. The good nonverbal communication is good when the patients are anxious. If they are having, then you learn and you see that they're feeding off of you and maybe getting, hearing what you're saying, understanding what you're saying. But as Molly said, there's going to be things you say that they don't understand. Now, whether that scares them or not, you don't know. So you do read the patient. You don't have to be super silent, but it's nice to kind of get in that habit of doing things. And you can have full conversations with these kids. You can joke with these kids. You can talk about what they're going to be doing after at the end of the day. And so, yeah, so it's definitely, the nonverbal communication is a helpful tool, but it's not a written rule. But when you're getting going, just kind of get used to doing that so that you can do it. But hey, if the kid wants to talk to you, talk to them. I know, like with the parents in the room or a visitor, sometimes they want to talk to you, and they used to talk to us all the time in the beginning. But then we saw anxious parent, anxious kid, and so we kind of learned to make the room quiet like a movie theater where you don't want anyone to talk, but sometimes somebody does, and hopefully they're not ruining the show. So yeah, that's just my additional 2 cents on the nonverbal stuff.
All right, great guys. So we are at time. I did want to squeeze in one more question though, because I think it's a good one, because it's a question about, kind of from the patient perspective, kind of how they're looking at this procedure. So, specifically to Mary and Molly, so how do you describe, this procedure to your patients, especially if they're concerned that it might not be right for them? I mean, kind of what kind of, concerns do the patients or their families kind of present to you when you guys are, initially having these conversations with them?
I guess I'll start. Often with that, if the patient has a concern, I will say, I'll ask them what their specific concern is, and I like to address that to get that out of the way right away, depending on what it is. Some will say, "Oh, is it going to hurt? I'm afraid it's going to hurt." Or one person was afraid they were going to gag because they have a real strong gag reflex, and you know what? It's really the patient. The numbing medicine works very well. Very few. A few patients do gag on intubation, but really I would say the majority don't. And so I just try and lay their fears at risk, or at rest. I let them know there's they may feel some movement, but there's no needles. That it's not painful. I let them know how short, it's only about 7 to 9 minutes. So I just try and, again, address any specific concerns that they have, and just let them know, what, and it's okay to try it. It is okay to try it. And we have had a couple that we had to abort, and that's okay. And we let them know that that's okay too, So that's how I would handle that. I don't know if Molly has something more to add.
I think that's absolutely right. I usually start with that. I usually say, hey, it's not for everyone, and that's okay, but here's some reasons that it might be for you, or maybe why it might not. And I think it's just important that you're open and honest and let them know that either's okay. I like to talk about the advantages over a sedated endoscopy. For a lot of kids, that's really the draw. They really don't like the way anesthesia makes them feel. They don't like that they have to miss a full day of school, that they can't do sports. They don't like needles, something like that. And so a lot of times that's the starting point of the conversation. And then we can say, okay, so that's what your draw is to doing this procedure. Okay, so then here's your concerns. Is that concern more or less than the draw? So that's something that I've done. Can always reach out to Child Life, right? So our Child Life is very involved, and they usually get involved like once they're scheduled. But if they're still thinking about it, there's no harm in saying, hey, like, can you give them a call now and see, if you can get a better read, give them some better tools now to make this decision. And then, if they ask me questions, I will answer them honestly. And, I answer them in a non-scary, non-threatening way, but I do tell my patients that I'm honest with them. So if they say, like, how does it feel? I'll say, most patients do not say it hurts. It really shouldn't hurt. You might feel a little bit of pressure. One patient had a little bit of discomfort at the nose. That shouldn't happen. And what we learned is that if we do this, that doesn't hurt anymore. So you can tell us and we'll make that change for you. So we have very open dialogue. And ultimately we say, if you try it and you decide you don't like it, that's okay. We'll just schedule you for a sedated one later. And just let them know that's okay. And I think that's the biggest thing, that they don't have to feel ashamed if they can't do it.
Yeah.
All right,
I like
awesome. Yeah. Ooh, go
I
ahead.
just one thing I like to do is ask them which finger they pick their nose with, and just tell them, just to get as far up as they can, and then show them or compare. You tell them that the scope is a half, a lot smaller than what their finger is, and it's nothing to be scared of if they're always picking their nose. So.
All right, words of wisdom from our man Clint here. All right, so I have just a couple more questions in from the audience, and then we'll go ahead and wrap up. I have a nurse that just typed in a question based out of Kansas City, who I guess it sounds like is involved with setting up an EvoEndo Unsedated TNE program at her hospital. So love to hear that. And so she has two questions. One, do you guys have any experience with flavored lidocaine? And then the second question from the same individual is, have you had, or has anyone basically done a TNE with a deaf patient, or had any experience with kind of how to manage it, from the perspective of a hearing impaired individual?
Regarding the flavored lidocaine, we have not personally used that. We do know of another facility that is using that, and that's something that we are going to be looking into. But as of now, we have not currently used that. Regarding the deaf patient, we haven't done a TNE on a deaf patient, but we did an awake esophageal manometry on a deaf patient a few years back. Probably 4 or 5 years ago already. So if you still, I know that nurse had our contact information at one time, had my contact information. So if you still have that, reach out to me and we can talk about that, that experience if you would like.
Yeah, the flavored lidocaine, I know Rainbow Babies and Children's Hospital has used that some. I believe Dr. Friedlander tried using some hurricane spray in the beginning. That was like a cherry flavor, but a lot of the kids reported that burnt. And so we've found that the lidocaine usually is the worst experience, and a yucky taste is a lot easier to kind of work through than a burning discomfort. But Rainbow Babies and Children's, I believe they've been using some, and like Mary said, she can, we can get you in touch with them. As far as a deaf patient, I don't think, and Joel, you can correct me if I'm wrong, I don't think we did any deaf patients. We did have some, non-English speaking patients. So that communication barrier was there, but we did have an interpreter there to kind of help us walk through. But I don't think we did any deaf patients. But as Mary said, they had experience with esophageal manometry, which is very similar to unsedated TNE. So yeah, and Joel, do you remember anyone? I don't
No,
think we.
we hadn't. No.
Okay, there you go. So
All right, very good. Well, we are over time, so I'm going to go ahead and wrap this session up. Thank you so much to our panelists. We really appreciate you taking the time to, kind of participate in this with us and provide education to, to our customers and the general audience. To the audience, thank you so much for taking the time out of your busy schedules. As a reminder, we will be pushing this recording out within the next few days via email. It'll be a publicly, it'll be a link that you feel free to share amongst your working groups, colleagues, peers, et cetera. We appreciate, or we encourage kind of that sharing of information here at EvoEndo. And yeah, so that's a wrap. So thank you so much, and everyone have a wonderful evening.